Hey all, so today I'll be talking about a class of neuromodulating tools called transcranial direct current stimulation and its relationship to the alleviation of chronic pain. tDCS is a neuromodulation technique that produces intermediate and sometimes lasting changes within the brain. At the most basic of levels, the physiological mechanisms of tDCS consist of the subthreshold modulation of neuronal resting membrane potential. In this instance, the usage of tDCS leads to a point of excitation within the resting membrane potential that can create stable and time-bound changes of plasticity within the pattern of already active neurons and synaptic channels. These changes within the membrane of the neuron are also known as EPSPs, or excitatory postsynaptic potentials, which are basically little bumps that make a neuron more likely to fire. Now suppose we apply this knowledge in combination with the usage of tDCS. We can understand that tDCS acts as an external modulator that enhances the electric charge within postsynaptic membranes, which leads to changes within neuronal excitability. However, for the neuron's excitability to be of benefit, it is vital to know how to distinguish and select the location, length, and duration of stimulation within the usage of tDCS. This is where the electrodes known as the anode and cathode are essential to explain, as the positioning of the anode and cathode influence how the current of EPSPs flow throughout regions of the brain. Furthermore, the effects of tDCS are polarity dependent, in which anodal stimulus of tDCS enhances activity, whereas cathodal stimulus of tDCS diminishes excitability. And if delivered with the correct positioning of the electrodes, it can result in the curation of a neuroplastic state of the glutamatergic synapses, and which thus can lead to alterations of cortical excitability. To visualize this, I like to think about the brain, or a particular set of neurons, being a student within a class who keeps on distracting others, and tDCS is the teacher who comes along and clicks at the student to boost their productivity in the right direction. Now that we have a sound basis for the physiological mechanisms of tDCS, I will now discuss what chronic pain is and how the mechanisms behind tDCS can help with the alleviation of chronically related pain conditions. To most people, pain is an unpleasant but short-lived experience caused by illness or injury. Traditionally, doctors have divided pain into two categories. Let's say you stub your toe on a door. That would be considered nociceptive pain. The initial damage to that tissue, in this case the toe, generates a nerve impulse that moves up the sensory pathways into parts of the brain. The brain recognizes the impulse as the danger, generating the pain response to tell us where it is coming from. However, a nerve fiber can also generate an impulse entirely by itself, telling the brain there is danger without apparent tissue damage. This is called neuropathic pain. Examples include sciatica, shingles, and peripheral neuropathy. Although tDCS is a relatively new tool of neuroscience, there have been several findings that have shown noteworthy results of its usage within the alleviation of chronic pain, especially regarding neuropathic pain. This is because tDCS has the unique capability of targeting specific brain regions that are related to pain. For instance, in a controlled study conducted by Hagenaker and colleagues, they found that with the anodal stimulation of the motor cortex, they were able to significantly reduce the pain for an extended period within participants who were diagnosed with trigeminal neuralgia, in which their evidence described that they were able to reduce the pain through the anodal tDCS of the primary motor cortex, which was placed contralaterally to the symptomatic side of facial pain the participants reported. The reasoning behind why this works is because tDCS can inhibit or excite the motor cortex, which is one of the main areas of the brain that contain a number of networks that are responsible for the interpretation and with the alleviation of neuropathic pain. However, experts now recognize a new category of pain caused not by tissue damage or agitated nerves, but by an error in the body's danger detection and pain processing abilities, which is now known as nociplastic pain. To understand this correctly, let us take a closer look at how nociplastic pain is experienced within the body. There are two primary pathways for pain signals. The first is the sympathetic nervous system, which sends an impulse up the spinal cord from the site of the injury to the brain. This is what we know as nociceptive pain and neuropathic pain. However, in the secondary pathway of pain perception, the parasympathetic nervous system sends calming signals back down the spinal cord, telling the body not to worry. In nociplastic pain, these calming messages get lost, and painful sensations start to be felt routinely, as these painful sensations increase in a feedback loop as the central nervous system becomes hyperexcitable and amplifies the pain response. And once this happens, even everyday things like brushing your teeth can become unbearable. Moreover, the problem with nosoplastic pain is that it can manifest without any visible or structural abnormalities, making it extremely hard to diagnose and to mediate. With the usage of tDCS, we can expect that it may help in the production of these calming signals within those who experience nosoplastic pain. For example, it has been shown that with the usage of tDCS, it can improve pain symptoms in fibromyalgia, as the anodal stimulation of the dorsolateral prefrontal cortex has been shown to release inhibitory neurotransmitters such as GABA and endogenous opiates within patients. The downside to this is that some patients frequently either stated that their experiences of alleviation from tDCS were either short-lived or non-effective. As for the future, we should consider non-invasive brain stimulation with tDCS as an effective tool that should be used to treat pain syndromes. However, we need to account for the lack of variability. To do this, we need to enhance our knowledge of the types of pain and how these pain types are experienced within patients. Understanding these underlying processes will help us understand conditions that can be modulated by tDCS. It is also crucial that formal and comprehensive training is provided to those utilizing the tool, as it is necessary to ensure that tDCS is delivered to patients using an effective and consistent approach. The adherence to these statements will help develop more efficient tDCS protocols and help shape the effects of tDCS to enhance its analgesic capabilities and reduce individual inconsistencies. Thank you for listening.